An opportunity for us to share the work on diabetic retinopathy, and I'd like to really congratulate Dr. Rohan for the work which he's been doing at a secondary level. And if you calculate, it's nearly about 10 patients a day, which is really a big number, which even in a tertiary care center when we started teleophthalmology we could not achieve. Really good work by him. I'll be sharing on one aspect of telemedicine which is used for screening of one of the disease, diabetic retinopathy. And 1 in 6 has diabetic retinopathy. So it is very common in people more than 40 years. We also looked into that it is not only the urban area but even in the rural area the prevalence of diabetes and diabetic retinopathy is alarming. The good news is that it is an avoidable blindness, and the answer for this avoidable blindness is screening for diabetic retinopathy. We have two types of models for screening. We have what we call as ophthalmologist based model, where the screening is done by ophthalmologist. His physical presence is required. He does a dilated retinal evaluation, and the screening is done by indirect ophthalmoscopy. But as the previous speakers have told, there is a big difference as far as doctors population ratio is concerned in rural areas. So the second model is a telescreening, where a physical presence of ophthalmologist is not required. The paramedical staff acquires the images and the data. They are transferred by any means, by a satellite or by VMAX or by Wi-Fi, and these images are interpreted by the ophthalmologist and a report given to the patient. Now, this was another one study we did with site savers, that which is the best method for screening diabetic retinopathy. We have screening by physicians, by optometrists, by ophthalmologists, telescreening, and so this was about 400 diabetics 2009-2010, and we compared the gradings with a standard 7-field ETDRS one, and we had these groups. We had undilated direct ophthalmoscopy by optometrist, undilated direct ophthalmoscopy by physician, dilated direct ophthalmoscopy by ophthalmologist, indirect ophthalmoscopy, undilated 45-degree, and dilated 45-degree single photograph. And what we found that if we look at the first model, the ophthalmologist based model, the indirect ophthalmoscopy by ophthalmologist, the sensitivity specificity is pretty good, about 95% specific, 77% 95% sensitive, and about 77% specific. And if we look at ophthalmologist-led model, that is the telescreening, a dilated 45-degree single photography gives us a good sensitivity specificity to be used as a screening method. And that's what we use. We use a dilated 45-degree centered on the fovea, the single field photography. With Lions Club International, we did a telescreening program between 2003 to 2006, and we had both the models. We had a model where we had ophthalmologist-led, that is the telescreening, and ophthalmologist-based, where the doctors used to go and do the screening camps. We had the opportunity to compare these two, and we do see that prevalence of diabetic retinopathy was little more in the ophthalmologist-led model. So we do see that telescreening gives a little bit what we see in ROP, the funnel effect which is seen. However, it doesn't overestimate or underestimate sight-threatening diabetic retinopathy. So we may say a person who has no diabetic retinopathy, we may say that he may be having early stages of retinopathy, but a person who has sight-threatening retinopathy will not overestimate with telescreening. Again, if we talk about screening, we do know that there are two types. We have opportunistic and a high-risk screening. Opportunistic screening is that we do an examination of retina, we do a retinal examination as a part of a comprehensive eye examination. He has come for cataract or he has come for glaucoma, and we do a screening for diabetic retinopathy. High-risk screening is we take only diabetics. And if you are diabetic, then only we do eye examination, or those who have nephrology clinics where we get lot of diabetic nephropathies. We know That those who have microalbuminuria, 2 times more risk of retinopathy. They have frank albuminuria, they have 6 times more risk of retinopathy. So that's again, we go as a targeted camp so that to have a more yield. So that's what the opportunistic screening is. This is the ideal screening method. It is a part of a comprehensive eye examination. And the advantage is we'll have a wide coverage. High-risk screening is target one, like diabetic retinopathy screening, and the advantage is we get a more yield of diabetic retinopathy. Because we know that if we see 100, hardly about 18 to 20 will have retinopathy. And those who are sight threatening will get only 4 to 5. So to get a more yield, we do a high. So actually the opportunistic screening and the high-risk screening, they complement each other. So if somebody wants to start a diabetic retinopathy program, he needs to do both the programs together. How we transfer the images, we do use both store and forward and real time. Store and forward is the data and images are stored and then it is forwarded to the ophthalmologist for later retrieval. Real time is simultaneously both the things are done. And we did look into the time which is taken for both real time versus store and forward for a single patient. Now the technology has changed, but this was in 2004. But that was the time we wanted to look at which is the best method when we are doing the mass screening. When we have 300 or 400 patients coming, we found that the real time works better in a camp setting. We also looked into the transmission losses, the image quality, how much it reduces. Now with the newer Wi-Fi and the other net connectivity, because this was by the satellite connectivity, we did see that if we compress, because there the images were compressed and then sent, so compression of 40% was adequate. So now presently for a high-risk screening where we do a camp, a diabetic retinopathy screening camp, we use a real time. And for opportunistic screening, when it's a part of eye examination comprehensive, we use store and forward. This is a small video which shows the telescreening van. So this is our teleophthalmology van. So in a village panchayat, the optometrist, he registers. He takes the basic history. In diabetic retinopathy, again this is very important. Patients go inside the van. We use a satellite connectivity. It's provided by Indian Space Research Organization, and the data and images are transferred to Shankar Netralaya. So here is a patient who has diabetic retinopathy, so examination is done, vision. This van has got all the equipment for anterior and posterior segment examination. Slit lamp evaluation is done by the optometrist, and the photography is taken. That's a non-midriatic, so 45 degree single field photography. So he has sight-threatening macular edema, and the doctor sitting at the base hospital sees the images, gives the diagnosis, and he directly converses with the patient regarding the need for the treatment. This van is also accompanied by a smaller van which has a spectacle dispensing unit, so it has got if patient needs just the glasses, he is being provided the glasses, and the van goes to the other village. Again, as I had mentioned, how many fields are needed, though variety of studies have used various fields, but what we use is a 45 degree single field photography. These were some of the studies which we proved that this is good. Even the American Academy guidelines have now shown that for screening a single field posterior pole images are enough. This was again one interesting fact we tried looking at. Do we need to dilate the pupil even if we are using a non-midriatic camera? Though the concept is that non-midriatic camera, you don't need dilatation, but we did observe that even with using a non-midriatic camera, if we don't dilate, because in our population we know there is a high prevalence of nuclear sclerosis, especially among the diabetics. So the image quality is usually compromised. These patients, even if we are using non-mydriatic, we dilate and take the images. We did see that the rejection rate of the images reduced from nearly about 30% to 8.6%. That means those who have cataract, better to dilate and then take the retinal images. The chances of getting a non-gradable images were far less. We tried looking at the cutoff values and we did find that people more than 59 years and vision is less than 612. These are the patients, even if you are using a non-mydriatic camera, better to dilate so that the chances of getting a good gradable image would be high. And that's what the protocol we follow in our teleophthalmology. We did a lot of validation studies to look into this was one thing because the teleophthalmology had just started 2002-2001. We were keen to know how much it agrees with a in-person evaluation by ophthalmologist. It agrees pretty well. We also looked into the patient satisfaction, whether the patients are satisfied, and this was a qualitative study. It does tell that both in-person evaluation and telescreening, both are very gratifying, and the reason they found one of the factor was that patient is happy seeing his own image on a television screen. So he was very satisfied. We also looked into the costing, how cost effective it is, and this was again, after that we came out with a diabetic retinopathy cost effectiveness, and both of them does prove, as in other Western studies, that screening for diabetic retinopathy is very cost effective by using telescreening. We then did a large scale implementation 2005 to 2010 supported by World Diabetes Foundation, having again a mobile unit with a satellite connectivity, having all the components of awareness, screening and training, and during this 5 years we covered some districts, 6 districts of Karnataka, and had nearly more than 50,000 people screened, diabetics screened for diabetic retinopathy during this time. The future is the level 4, as morning we were just discussing with Dr. Sunil, that it is not only eye examination, these diabetics need a comprehensive evaluation, and this was a model which we made in which we have even a semi-automated analyzer inside the van, tests for neuropathy, tests for nephropathy, so that a comprehensive evaluation of a diabetic can be done inside a van. This van we had used for epidemiological study in rural areas. The next initiative which we are now starting is initiative with the industry, leveraging the general physicians for eye screening, where we have 100, we are planning 100 fundus cameras across 20 cities, and all these images come to Shankanetralaya and we give the grading from there, and those who need treatment, our alumni in the city itself take care of them. The other things which are developing in telescreening is miniaturization of diagnostic equipments, and I'm sure all of you might have seen the mannequin with the bike having a small fundus camera in the trade today. So we do know that the equipments are reducing in size. There is work on automation of diabetic retinopathy diagnosis, and with newer 3G, 4G, we have now better telecommunication. There are, regarding diabetic retinopathy automation, there are now softwares which can tell us about the presence or absence of diabetic retinopathy. Commercially available one is the red marker, and there are a lot of groups who are working on their own image analysis software, and we tried looking at this, which is already available, that how much accurate it is in diagnosing diabetic retinopathy, meaning that you just take the image and the software tells whether the patient has retinopathy or not. So no need for transmission also. The currently available softwares have got low sensitivity specificity. It improves when we increase the image quality is better, you have a better one, but till today there is no definitive answer as far as automated analysis is concerned. So in conclusion, we have ophthalmologist based or ophthalmologist led model, we have opportunistic and a high risk screening. We are doing ophthalmologist based. Indirect ophthalmoscopy is a good method, dilated indirect ophthalmoscopy. going through a telescreening, fundus photography, single field 45-degree photograph is reasonably good. Thank you very much.